This session is on glycemic monitoring and a bit of a look at some of the newer technologies within the space of type 2 diabetes. So as you heard, I'm a GP. I practice in a diabetes clinic in northern Tasmania. And with respect to the ECHO project, I have no conflicts of interest or disclosures. So what I'd like to cover is to just very, very briefly look at an overview of how we monitor glucose in people with type 2 diabetes, and then look at some of the newer technologies and what role they might play. And ideally, this should then give us a little bit of a direction in terms of who would benefit from these technologies. So I've no doubt that Lord Kelvin was not thinking about glycemic management when he said, if you can't measure it, you can't improve it. But this applies, of course, as much to glucose management as it does to any scientific endeavor. So what are our tools? We use HbA1c, a well-validated tool since the 90s. It's a very good predictor of risk. It gives us an insight into long-term management over the preceding 2 to 3 months. We also, of course, have our main weapon of choice, if you like, is finger prick testing, which is ubiquitous and has some advantages in terms of low costs of entry and low learning curve. But I guess the greatest interest, particularly in select people with type 2 diabetes, and certainly pretty much anyone with type 1 diabetes, is continuous glucose monitoring or flash glucose monitoring. So HbA1c, as I said, validated, good, robust tool, but the problem is that an HbA1c of, say, 7%, as you can see here, really just gives us an indication of the area under the curve, but not the shape of the curve. And here, this graphic really points it out very well. So you've got a profile on the left where somebody is spending 40% of their time in hyperglycemia, 20% of their time in hypoglycemia, and only 40% of time in range. The middle graph is probably a more typical one of what we'd see in clinical practice, 70% of time in range, which actually equates quite well with an HbA1c of 7%, 5% hypo, 25% hyper. And of course, what we aspire to is to spend all the time in range. So 7% is not the same in everybody. And unless you have some other way of ascertaining the shape of the curve, not just the area under the curve, you really are unable to impact meaningfully. So if we look at the curve on the left, if you were to want to intensify therapy, we would just cause more hypoglycemia. So what about finger prick testing? As I mentioned, that's ubiquitous and used in the majority of cases. So who should do finger prick testing? And the reality is most people should not with type 2 diabetes, particularly if there are medications that do not cause hypoglycemia, DPP-4 inhibitors, GLP-1s, metformin, and so on. So self-blood glucose monitoring is useful medication-wise where there's a possibility of hypoglycemia. For those who are not on insulin or sulfonylureas, if they're struggling to achieve glycemic control, so the example would be lots of glycemic variability, as I showed you in that earlier graph. And then, of course, things can change very rapidly if people have an intercurrent illness, so they could be toddling along quite nicely, but then things go awry. And they may even need to be put on insulin temporarily, depending, of course, on how significant that hyperglycemia is. Or, of course, if they have an illness where they're not eating and they are on medication such as sulfonylurea, they may be at risk of hypoglycemia. We want very, very tight glycemic control pre-pregnancy and pregnancy. And so monitoring very, very closely would be, of course, advantageous to both mum and bub in terms of clinical outcomes. And it is a very useful learning tool where we have a change of lifestyle. So it might be an indication of what certain foods or physical activity does to the glycemic profile. So it's really targeted glycemic monitoring. It's not just somebody doing fasting finger pricks in perpetuity, coming in with a number every morning, which really doesn't inform us terribly much. So it has to be targeted specifically to answer whatever question is being posed. And of course, there are situations where HbA1c is unreliable. So hemoglobinopathies, end-stage kidney failure, someone's had a bleed, transfusion, and so on. And of course, the tool is only as good as its interpretation and implementation of the results in terms of making meaningful clinical changes. So it's one thing doing the test, but it's also another taking action. And certainly, I'm sure you've all heard of people who do this finger prick test, they present it, or they present for their diabetes review and nobody even looks at it. So like every investigation, every test we do, it should be answering a clinical question. If you're struggling to find the clinical question, don't do the test and don't get your patients to prick their fingers. It hurts. So self-blood glucose monitoring, as you can see here, this is the kind of thing we get. Doesn't look too bad. The problem or the shortcoming is not what you see, but what you don't see. So if we overlay a continuous glucose profile, you see what you've been missing. There's significant hypo and hyperglycemia that you could not identify unless you did lots and lots of finger prick testing. And of course, many people are reluctant to do so, or if you have continuous glucose monitoring. And of course, this brings us to the newest kids on the block, and that's continuous glucose monitoring and flash glucose monitoring. So continuous glucose monitoring and flash glucose monitoring, also called intermittently viewed continuous glucose monitoring, because there's a great deal in common between these two modalities. This measures interstitial glucose levels, not blood glucose levels. That's critical because when glucose levels are changing rapidly, there can be a significant discrepancy between blood glucose and interstitial fluid glucose. So having continuous glucose monitoring or flash glucose monitoring does not certainly eliminate the need for finger prick testing. But again, as mentioned before, they need to be targeted. So if somebody is heading lower, they might have a glucose of 5, but because of that lag, their true glucose may already be entering hypoglycemia. Confirming that with a finger prick test and taking the necessary action would be useful in that situation. So who would benefit from this modality, from these technologies? Again, pretty much the people who you would do finger prick testing on. Somebody who is at high risk of hypoglycemia, somebody who may have hypoglycemia unawareness, in which case their window of opportunity to respond is very low, and these are high risk individuals, and those who have high glycemic variability. Once again, sugars are bouncing all over the place, struggling to understand why the control is not happening. And when you get this incredible detail that this technology gives you, you get a much greater insight and granularity to the glucose profiles, and you can then hopefully tease out the causes and put into place some remedies. So as with all of medicine, this is very much a case-by-case basis, individualized according to the patient's desires, needs, and potential benefits. So how it works, flash glucose monitoring, the Freestyle Libre, glucose sensors inserted into the subcutaneous tissue and connected to a transmitter. So there's a transmitter and sensor within the unit, and a handheld monitor or compatible smartphone will receive data from the sensor by waving or flashing the reader of the sensor. So you have to actively get that before you can act on any information. But you will be getting continuous readings, so you do get a graph and a trend which allows you to take action. Now, this is almost obsolete in the sense that Freestyle Libre 2 is available overseas and soon to be available here, and it'll talk directly to your smart device, so you won't have to do the flashing. And I'm embarrassed to say that Libre 3 is already available overseas, and we're still stuck in the slow lane in Libre 1. But just be aware that Libre 2 is coming very, very soon, and so some of this may in fact be out of date. Continuous glucose monitoring. So this has been a preserve, I guess, of type 1s for the most part. And the greatest utility of this is if you can get a semi-closed loop where it talks to the pump. So once again, quite similarly, you've got a glucose sensor, which is this over here, which is inserted in subcutaneous tissue and then connected to a transmitter, which is a separate device. The glucose sensor then sends values to the transmitter, which in turn transmits wirelessly to either a pump or a handheld monitor or a smart device. And these readings are occurring every 5 minutes or so. And it's very similar with the Libre as well. So you're getting 288 data points a day, which is an enormous amount of information and allows you to see where the glucose is going, where it's been, and to take, as I say, preemptive action. So how do you make all of this data accessible? So, 288 readings a day. If you see somebody weeks later, it's in fact thousands of readings. A very different proposition to reading a few blood glucose results in a blood stain record book. Here you need some way of crunching that data and presenting it in an accessible way. And that's what the ambulatory glucose profile report is. So it's a standardized single-page glucose and insulin report, and you can see some of that detail on the right-hand side, and includes summary statistics, and they're in fact 10 metrics that have been included in this AGP, or ambulatory glucose report. And these include glucose profile graph, insulin profile graph, if people put the data in, and there's also a daily calendar. And the idea is to make this consistent, irrespective of the device. We're not quite there yet. So this is meant to be like the glycemic ECG. Now, if somebody hands you an ECG, you probably have no idea whether that's a Hewlett-Packard or a Mitsubishi or some other device. They all look the same. They all are pretty much identical. And you're agnostic to the source, whereas here there are still some differences. But the attraction of this is the graphs are easy to follow, allow for pattern recognition and interpretation, and it is accessible not only to clinicians, but really the patients themselves immediately see where the problems may lie. So here you've got a median, the blue line, the dark blue line is the average glucose. The darker shading is the interquartile, so the 25th to 50th percentile, where you have 50% of the glucose levels falling. And then finally the lighter blue or lighter gray is between the 10th and 90th percentile. So that includes 80% of the data. So there's still 20% that's not displayed here, and that's the 10% that's lowest and highest. So that's important to be aware of. Here you can see that there's hypoglycemia occurring, in between 4 and 6, or in fact, between 4 and 8 a.m. But sometimes if it just approaches that and you don't see it, you may be missing some hypoglycemia if you don't look at the actual profile. So what are the recommended targets? As you can see on the left, this is for most individuals, target within range of greater than 70%. And as I mentioned, there's good correlation between 70% in range and an HbA1c of 7. So we're not reinventing the wheel, but just finding a different way to present those similar targets. In those individuals who are at higher risk, we are happy to allow for less time in range and more time spent in glucose between 10 and 14. And of course, we desperately want to make sure that we eliminate hypoglycemia if we can. During pregnancy, we like time in range to be 70%, but here the notable thing is that the range is different. It's 3.5 to 7.8. So we're looking at euglycemia 70% of the time. And finally, gestational diabetes and type 2 diabetes. This is our case presentation. No one can agree, so your own best guess as to where people should be. There are no guidelines as far as that is concerned. So I thank you very, very much. And I hope that that Cook's tour gives you a little bit of an insight into where the technology is heading.